Good evening, everyone. I'm Haley, and on behalf of Team Medflix, I'm thrilled to welcome you all for today's session. Coming to today's session, today's topic is heat-related illnesses, a topic that's special and relevant because we are entering the summer season after all. I'm glad to welcome Dr. Mahadev Desai sir with us today. He is a senior consultant physician at KD City Center Hospital, Ahmedabad. Welcome, Dr. Mahadev sir. Thank you so much for joining us today.
Thank you, Dr. Haley. Good evening to all. Thank you very much for joining this. And today we have kept this topic because we have already entered the and seen the mercury rising to 40 or 41 degrees centigrade part of India. And there are so many illnesses which can be covered under the heading of heat-related illnesses. And we are not going to talk all. That's why we have kept the title of ABC and not A to Z of heat-related illnesses. My disclaimers, there is nothing that I have to disclose. Only thing I must say that we have a grateful acknowledgement to all the websites and sources of information from where I have taken the pictures and the informations. And even if we are going to suggest some of the medicines or the drinks, sports drinks, something, it's simply out of context. It's because of the related to context and I'm not endorsing any of these drinks. Before we begin, we have to have something about why the heat-related illnesses are on rise. We know that the Earth's average surface temperature has been increasing at an unprecedented rate, especially for the last 50 years. If we see the temperature of the Earth before 100 years, it was around 15 degrees centigrade. And global average temperature has increased by 1.7 degree Fahrenheit or 1 degree centigrade from 1970 to 2023. And we know the impact of global warming. We know that because of the global warming, we see rising sea levels, we see frequent and intense extreme weather events. At one part of the world, we find the famine, the other part, you find the floods. Places like Dubai also was flooded with water only before a year. So that's all because of the impact of global warming. And WHO and all the wise nations are very much after the global warming, and there has been an agreement called Paris Agreement. It was decided before 10 years in 2015 that we must make all efforts to bring down the rise in the temperature to below 2 degrees centigrade and preferably 1.5 degrees centigrade. And we have to stabilize the global temperature and make it possible to have carbon neutral society. What we mean by carbon neutral society is that we must not produce more carbon than what we can absorb that carbon by other means. And to eliminate that, we must eliminate all emissions of heat trapping gases or what we call greenhouse gases, right? That comes mainly from the consumption of fossil fuels, which comes in the form of oil, petrol, kerosene, diesel, all those things. So we must make sure that we try to minimize the greenhouse trapped gases, as well as we must use as much of renewable energy as possible. Otherwise, the future generation will not pardon us and will make the heat related illnesses very frequent. As such, it is already on the rise. So with this prologue, I'm going to discuss the topic under the headings of what are the spectrum of heat related illnesses, what is the physiological response to heat when it comes to the extremes of heat-related illnesses, then what are the signs, symptoms, management, and prevention of heat-related illnesses. So the spectrum of heat-related illnesses can be broadly divided into the diseases or the disorders that we see because of the direct effect of the heat on the skins, and those which are because of the systemic effects of the heat. So what we see because of the effect of heat on the skins are sunburn, heat rash or called prickly heat, and heat edema. While the systemic effects may be heat cramps, heat tetany, heat exhaustion, and heat stroke, also called sunstroke. So these are the illnesses that all will be covering one by one. But our major focus will be obviously on the serious illnesses like heat exhaustion and heat stroke, because these are the life-threatening illnesses and they have to be diagnose in time, and treatment should be started as soon as possible. So sunburn is because of we know that the sun rays produce UVA and UVB rays, ultraviolet A and B rays, and the ultraviolet A rays penetrate right up to the dermis and the subcutaneous tissues, while the ultraviolet B rays go right only up to the epidermis. And this ultraviolet rays, both UVA and UVB, directly affects the skin and can produce painful red warm skin, which is called sunburn, and it may go into the formation of blisters. So sunburn is the first sun related or heat related illnesses, and treatment is very simple. Just stay out of the sun until the sunburn heals. Put cool clothes on the sunburned areas or take a cool bath. Then put moisturizing lotion. You don't have to apply very creamy lotions because you need to have some aerations of the tissues, and do not ever prick the blisters. You should use the sunscreen which has available in the form of the ointments or the lotions, where we decide the efficacy of the sun preventions by way of sun protection factors called SPF. And these sun protection factors should be minimum 30 or beyond. And this is very, very important that we must apply it for at least 15 to 30 minutes. And this has to be applied every 2 hours. What the common mistakes people do is that they apply the sunscreen but only once or twice. That's not enough. Even when we go out, when we go to the hills or when we go to the, say, Leh Ladakh or Mansarovar, the sunlights also reflect from the ice and the snows. And that is why it said, if you read the first line, it is UV light reflected from the sun directly or through the surfaces can produce the sunburn. So you have to be very careful. You should also be using the hats and the goggles and all that we'll see later on. But sunburn is to be taken care by the local applications. The next one is prickly heat or called heat rash, or also there is known name lichen tropicus. This is where there is an actual inflammation of the sweat glands and blockage of the sweat glands and producing inflammations. So the person would present with erythematous rash, and this will be appearing as small itchy red bumps, and which gives a sensation of pricking or stinging sensations, and that's why it's called prickly heat. And usually it is seen more when there is a normally more perspirations. So neck, chest, shoulder areas, back, groin or armpits are the places where we expect the more prickly heat or heat rashes. Again, the treatment is the apply a cool damp cloth or an ice pack. That don't apply the ice directly, but put it in a towel and apply it. Then avoid over dressing. And again, do not scratch or do not push too much of oily cream. All that is required is apply something like soothing ointment which has some property of preventing and not blocking the sweat glands, that is calamine or lactocalamine lotions. Most of these ointments have the titanium oxide or zinc oxide as one of the main important ingredients because they reflect the heat. They do not allow the heat to get absorbed. The third, not very common, but seems in people who are not acclimatized or who are elderly, that because of the acute vasodilatations and the orthostatic pulling of the interstitial fluid, person may develop edema. And that edema is usually in the dependent part, but it can be seen also on the extremities. Usually it is self-limiting. All that you need to do is take away the patient from the extreme heat and allow the patient to elevate the legs. But at the same time, we must make sure that edema, there is no other cause or other serious cause, because there can be some conditions like deep vein thrombosis and which can have potential of pulmonary embolism. So do not ignore the symptoms or signs if the patient has unilateral swelling, calf pain, breathlessness, chest pain, or tenderness or discoloration of the skin. So that's very, very important. Otherwise, heat edema per se doesn't require any treatment. So we dealt with the local conditions. Now we go to the systemic effects of the heat, and there the main conditions are though heat stroke and heat exhaustion, but more common are the heat cramps that we see in practice. And heat tetany is not very common, but again once in a while we do see. We'll discuss heat tetany first because the heat cramps, heat exhaustion, and heat stroke are in almost a continuum, or you can say it's in more frequently. Heat tetany is a condition because of the extreme heat and heat stress, that a person is sudden exposure to a short periods of heat, then he might start hyperventilations. Whenever there is a hyperventilations, there is carbon dioxide was out and patient develops respiratory alkalosis. Whenever there is respiratory alkalosis, the calcium binding to the proteins increase, so the ionized calcium available is reduced, and that is the reason the person develops tetany. And in tetany, the patients had a typical complaint of paresthesia over the circumoral root, or there may be a carpopedal spasm. Carpopedal spasm is the patient has uh, comes with the flexion of the all the fingers as well as the metacarpal joints and the wrist and the thumb, and extension of the PIP and DIP joint. So that is a carpopedal spasms. And that if you want to confirm that there is a carpopedal spasm, we may tap over the in front of the external pinna, and then we'll get the twitching over the facial muscle. That is called a Kostek sign. So tetany, carpopedal spasm, and Kostek signs are diagnostic. And if we take the blood and send the blood for analysis, then the ionized calcium level will be low. Normally, the ionized calcium level is 50% of the total calcium levels. And so that's around 4.6 to 5.2 milligram. Some laboratories give in millimoles also. But less than half of this would produce tetany. ECG has a very interesting feature to remember. It has a prolonged ST segment, and as you can see easily in this particular cartoon, that ST segment, which is a flat line, isoelectric line between the end of the S wave and the beginning of the T wave, that is flattened, that is prolonged. So QT prolongation because of the ST segment prolongation is typical of the hypocalcemia. Treatment is very simple. Remove the patient from the heat, and if you want to prevent the carbon dioxide exhalation further, make the patient breathe his own or her own breath by giving a paper bag or a rebreathing mask, and that will take care of the further loss of the CO2 and further respiratory alkalosis. But in a patient with some arrhythmias or patients with a severe carpopedal spasm, we may have to give injectable calcium gluconate. Calcium gluconate should be given 10% of the 10 ml in 10 ml, 10 minutes infusions. That is how we remember. 10 ml of calcium gluconate, 10% of the calcium gluconate, infuse over a period of 10 minutes. We may have to repeat it after another half an hour to 1 hour. Earlier, we used to use calcium chloride, but calcium chloride is very irritant, and that's why calcium gluconate is easy to give and available easily. Next are the heat cramps. These are a painful spasmodic contractions of the skeletal muscles. Patient who has been doing exercise either immediately after exercise or after some latent period would complain of sweating as well as severe heat cramps. And this is more common in patients who are not acclimatized, who do not do regular exercise. And it is supposed to be the local deficiency of the sodium, potassium, or electrolytes and the water at the cellular levels. The treatment is very simple. Give enough of rest to the muscles as well as rehydration with waters and electrolytes. The WHO ORS solution is very good enough, and it contains nowadays the latest formula of WHO ORS solutions has less glucose and less sodium compared to earlier one. But that makes a difference more in the diarrhea. But here, all that you have to give is any kind of liquids with salt and waters, and ORS is good enough. Now we come to the actual serious illnesses due to the heat, and which has a systemic effects, and which if we don't treat in time, patient may lose life. And there are many complications that are attached to the heat stroke. So heat exhaustion and heat stroke are a very important complications, and time and again we have been seeing these patients. Even if there are no heat waves, even during the quiet place also, the particular type of heat stroke called exertional heat stroke can be seen even without the heat wave. So it's very important to remember in the differential diagnosis of certain conditions we'll talk about. But before we talk about the heat exhaustion and heat stroke, it's worthwhile knowing how the body regulates the temperature, because that is how here there is a problem of thermoregulatory failure. It is different than the fever where the thermostat is set high because of the release of cytokines and the pyrogens, which leads to elevation of the thermostat. So the body has to produce more heat. And that is why the person is shivering and producing heat. Here the patient is already having a more heat, and he has to dissipate that heat or lose that heat, and he is unable to lose that heat, and that is why he get heat stroke. So that's a basic difference between the fever and hyperthermia. So body temperature regulation requires, we know that we are all warm blooded animals, and whatever is the outside temperature, our body core temperature or internal temperature is maintained only with a 1 or 2 degree fluctuations. Even if the outside temperature is varying by 25 to 30 degrees centigrade external temperature, the internal body temperature is closely maintained with a range of 1 to 2 degrees. So even with the, if you are in the heat for some time, really our body temperature will not go beyond 1 or 2 degree. And mouth temperature, if we record, which is of course not the true core temperature, but that is what we routinely measure, which is around 37 degrees centigrade or 98.6 degree Fahrenheit, while the rectal temperature is around 100.4 degree centigrade or 38 degree centigrade. So we need to maintain the internal temperature so that the body functions. We know that the main functions are carried out by the what we call proteins. Proteins have enzymes and hormones. They have a peculiar characteristic of 3D structures, and they are folding and unfolding of the proteins that requires certain temperature. Beyond a temperature, these proteins will stop working and all the activities will come to a standstill. So body temperature, either too high or too low, will definitely lead to the organ injury and death. So the body temperature, what is the situation where produces more heat load? The heat load is mainly because of the heat produced by the metabolic processes. When we eat, we consume that lot of heat is generated, and also heat is absorbed from the environment. So the heat load is mainly because of the metabolic processes generating the heat, as well as the absorption of environmental heat. And heat dissipation, that is loss of heat, is mainly governed by the, we know that the conduction, convection, radiation and evaporations are the process by which the body loses heat. So the heat that is generated by the metabolic processes or environmental heat is the one, the load is sensed by the hypothalamus. Hypothalamus has the thermoregulatory centers and it senses it, and it naturally, it tries to produce, it gives signals to the autonomic nervous system, sympathetic and parasympathetic systems, that will produce more sweating, which produce more cutaneous vasodilatations, and heat is lost by way of evaporation. Person has vasodilatations, person has sweating, and that sweating will lead to evaporation. That is how we lose heat. But there is a catch. If the environment has not only the high temperature but also humidity, that evaporation is not as effective. So if the humidity is more than 75%, the evaporation becomes ineffective. And that is where we need to have other methods of heat loss. Otherwise, the patient would go into heat stroke. The methods, conduction, convection, radiation, evaporations are the ones by which we lose heat. But again, that would work only if the atmospheric temperature is less than the body temperature, then only it would so, but that doesn't happen, and that is why these are not enough for the heat loss, and we have to rely mainly on the sweating as well as the cutaneous vasodilatations, or we have to use these methods by way of certain treatment that we'll talk later. So what happens if there is a hyperthermia or high heat load to the system? It will produce more oxygen consumption, obviously will lead to more hypermetabolism, that will lead to hyperapnea and tachypnea. Beyond 41 degrees centigrade or 106 degree Fahrenheit temperature, as I said earlier, many enzymes denature. They stop working, and that lead to the multi-organ failures. There is also the release of cytokines which produce systemic inflammatory response. So it's also one kind of inflammations. And also there is production of heat shock proteins. Heat shock proteins are a topic by itself, and only if the time permits, if there are questions, we can discuss more about it. But heat shock proteins are our main persons with what we call as a chaperons, or that is what they save the day. They prevent the further damage. We'll talk more later. So what happens that there is a redistribution of the blood. The blood is shunted from the splanchnic circulation to the skin and muscles for producing more vasodilatation and more heat loss, which is at the expense of gastrointestinal circulations. Because of the GI ischemia, there will be increased permeability of the intestinal mucosas, and patient may have translocation of the lipopolysaccharides and gram-negative bacilli and produce sepsis. Again, in the body, there are certain tissues and organs which are very sensitive to heat, and one of them is liver, another is vascular endothelium, the other is neural tissues, and they bear the brunt most. And that is why heat stroke will find central nervous system is affected as one of the important manifestation of heat stroke. In severe cases, we may have multi-organ failure and disseminated intravascular coagulations. Elderly are particularly more vulnerable to heat because they have not enough coping mechanisms for heat loss or what is required when the person is subjected to high heat load. And that is why persons beyond the age of 65, 70 are always vulnerable. And in this particular hot season, they should avoid going out or remain exposed for a longer period. So, because they have a reduced ability to deliver heat to the skin, they have reduced epidermal area because of the skin shrinkage, and they have impaired vasodilatations. Plus, they are also have an impaired thirst mechanisms. They may be on multiple medicines which have got anticholinergic properties. They also have issues where they cannot move from one place to another. They don't take enough waters. All these things make them more vulnerable to heat injuries. So the first one of the two serious illness for the heat is heat exhaustion. It's a conditions which occurs when there is extreme heat and exercise uh, and sweating without adequate fluid or salt replacements. If the person continues to get exposed or doing heavy exercise in the hot ambient temperatures and there is not enough of adequate salt and water replacements, he is bound to get heat exhaustions. And when the body is not able to cool itself, which is the natural mechanisms of heat loss, if the body is unable to cool itself, then person has heat exhaustion, and if we don't treat, then it may lead to heat stroke. So heat exhaustion and heat stroke are, we can say, continuum of heat illness from moderate to severe intensity. The symptoms are non-specific, and patient may present with nausea, vomiting, headache, fatigue, myalgia. So it's very important that we have a high index of suspicions, and particularly in this particular weather, if someone comes with these symptoms, we must have heat-related illnesses at the back of the mind as a differential diagnosis of all such non-specific symptoms. Even the patient has syncope, patient has orthostatic hypotension or postural symptoms, patient has sinus tachycardia, tachypnea. But two important features that make it very highly suspicious of heat exhaustion is profuse sweating and high fever. Fever is not as high as, of course, heat stroke. It will not usually go beyond 104 degrees. 101, 102 degrees is the usual fever that we get. But there is always a fever, and profuse sweating are the important features for heat exhaustions. Treatment: these are the persons who should be shifted to cool place and give rest as early as possible, right? And whatever treatment we are giving should be continued during the transition also. Make sure that we remove all the excess clothes that patient might be wearing and put a cool clothes on the skin. We sprinkle waters and start the fanning so that the air moves. Then give the patient cool sport drinks if person is more exercising or more losing way of heavy or profuse sweating, then give sports drinks which contains salt, minerals and sugars. So many sports drinks are available, but as I said earlier, our homemade uh, buttermilk or coconut water or lemon water are just good enough, and this should be started. Whatever is available, we should be giving. The patient should be receiving more of salt and water containing liquids. That's very, very important. If the because of vomiting or nausea or patient is not able to take, it's time that we should shift the patient to the hospital and start the intravenous fluids and electrolytes replacements. For that, we have to, of course, need to get the blood reports also before we start this treatment. But treatment should not stop or withheld because of all these things. Now we come to the last part, and that is the heat stroke. Heat stroke is the most severe form of heat-related illnesses, and it's an actual medical emergencies, and it can take the patient to a coma and convulsions and death in a matter of few hours only. So it's very important that we pick up the heat stroke and start treating as early as possible. Traditionally, the heat stroke are classically divided into two types: classic heat stroke and exhaustion heat stroke. Classic heat stroke is one which occurs usually in the elderly people who are sedentary, and it occurs in during heat wave. While exertional heat stroke is one which occurs in the young athletes and who are overexerting in the high ambient air. So there are many differences, but these are the basic differences. Classic heat stroke is one where the patient has more of the respiratory alkalosis, while exertional heat stroke is one where patient has more of metabolic acidosis. So there are many important features. The age group, as I said, the classic heat stroke patient is usually elderly, sedentary, but no age group is immune for getting either classic heat stroke or exertional stroke. What we talk is the overall incidence, but that all patients, anyone can develop either a classic heat stroke or even exertional heat stroke if the person exerts to a level in a high ambient air temperatures, right? Usually, the classic heat strokes occur during the heat waves as an epidemic form, and we'll see so many elderly patients succumb during a heat wave when the heat exceeds 44 degree or 45 degree centigrade. While exertional heat stroke occurs sporadically and it can occur at any time of the year. The health status is usually the classic heat stroke patients are usually chronically ill. They have many underlying comorbid conditions, while generally the exertional heat stroke occurs in the patients who are overall healthy. The CNS dysfunction would be there in both types of classic as well as the exertional heat stroke. Sweating is usually absent in case of classic heat stroke, and that is one of the important features, that because the patient fails to sweat, that there is no heat loss, and that is why he develops all the CNS dysfunctions and the complications. While in exertional heat stroke, initially the patient would have sweating, and later on the sweating may not be there. The acid-base disturbance is, as I said, initially in classic heat stroke, his patient has metabolic alkalosis, while in case of exertional heat stroke, patient has metabolic acidosis and even lactic acidosis. Rhabdomyolysis, because of the severe heat related muscle cramps and the release of myoglobin, the patients would have rhabdomyolysis more common in the exertional heat stroke, while it's very unusual in case of classic heat stroke. The liver dysfunctions may be present in both, but it's mild in the classic heat stroke, while it's marked to severe in case of exertional heat stroke. The renal failure also is quite common in case of external heat stroke, and partly aided by the acute kidney injuries as well as the rhabdomyolysis, but it's not very common. And this is the very nice paper in New England Journal of Medicine in 2019, from which I have taken this chart. Calcium levels are low in case of exceptional heat stroke, while potassium is very high. Patient will have hyperkalemia. We have to have a constant watch about this for the arrhythmias. And creatine kinase or creatine phosphokinase is markedly elevated, both because of the rhabdomyolysis, or they are mildly elevated in case of classic heat stroke. So classic heat stroke and exceptional heat stroke both will have common features in the form of a triad. Whenever the patient has a triad of high fever, central nervous system symptoms, and anhydrosis, one thing that we must think of is heat stroke. Patient's fever, as I said earlier, is usually 40 degrees centigrade or more. That is more than 104 degree. And ideally, we should be measuring the core temperature. So the rectal temperature is all we should be measuring. Central nervous system dysfunctions is in the form of all neurological symptoms, whether the patient is altered mentations or confusions or irritability or abnormal behavior, agitation, seizures, and even coma. And patients, as I said, have failure to sweating mechanisms. So anhydrosis, which we can see either over the skin is dry or we can see the armpits. Normally, armpits are the one which will be wet, but they are also completely dry. That means there is a failure of sweating mechanisms, which may be initially present in case of external heat stroke. Patients may have the non-cardiogenic pulmonary edema, and the respiratory system would give the crepitations. And if the patient has coagulant disturbances, patient may present with DIC and the excessive bleeding. The complications of heat stroke are many. It can be, as I said earlier, heart failure, which could be pulmonary edema or cardiovascular failure or non-cardiac pulmonary edema, both. There will be renal injury in the form of rhabdomyolysis, myoglobinuria, acute kidney injury, fluid and electrolyte disturbances, all types we see, but usually many patients, we see elderly patients especially, that water loss is more than the salt loss, and that is why they may have hypernatremic fluid losses. That is important when we replace the fluids. Hepatic injury, because the liver is very sensitive to the heat injuries. Then hematological insult may produce microhemorrhages or frank hemorrhage or thrombocytopenia and DIC picture. So very, very important that it's not that always we have to think of heat stroke, that the other illnesses are not there in case of in this season. Especially the patients might have acute central nervous system infections in the form of meningitis or encephalitis or typhoid fever. Sometimes come with very high grade fever in these particular seasons. There may be cerebral malaria. Of course, it's not very common in this summer seasons, but past May, June, we might get both either the heat stroke or even the cerebral malaria. Severe sepsis is another important condition, but elderly people, at least one more condition we must keep in mind is neuroleptic malignant syndrome. This is a condition where the patient is usually has been taking drugs like antipsychotic drugs that lead to these complications of severe rigidity and spasms, and that producing increased heat and high fever and loss of consciousness and all the symptoms that are present even in heat stroke. So neuroleptic malignant syndrome is worth keeping in mind. Malignant hyperthermia, of course, is very rare, but it's a genetic condition because of the abnormal receptors and mechanisms in the muscles. And if that person has undergone, received anesthesia during the surgery, especially the muscle relaxants like succinylcholine or the inhalations agents like isoflurane or fluorine, then that person might develop sudden very high grade fever. So malignant hyperthermia is also worth keeping in mind. And another non-infective cause which is worth keeping in mind is thyroid storm. There also the patients will have very high grade fever, all the symptoms and including the CNS symptoms. So as I said, the fever and hyperthermia are different. Fever is what we see in patients usually with infections or inflammations, like the body's temperature is set to a new high because of the release of the cytokines like the interleukin 1 or interferon gamma or IL-6 or tumor necrosis factor alpha. And it can be because of the infection or non-infectious causes. And temperature does not usually rise above 104 degrees. And they respond to antipyretic. That's very, very important that these are the conditions where fever will be responding to the paracetamols or NSAIDs because they are prostaglandin mediated response of the cytokines. While hyperthermia, there is an actual thermoregulatory center failure. So it will not respond to antipyretics. Temperature may go right up to 104, 106 degree Fahrenheit, and it's usually because of the excessive heat productions or failure of losing heat and very high ambient temperatures. And the important conditions, of course, are the heat stroke, thyroid storm, certain drugs, and malignant hyperthermia, as we discussed. So what investigation we should be sending when the patient has got the suspicion of heat stroke? Complete blood counts, urine analysis with a special mention for myoglobinuria, liver function state, renal function tests, serum electrolytes, sodium, potassium, chloride, calcium, phosphorus, magnesium, all, plasma glucose. If we have suspicion of thrombocoagulopathy, then prothrombin time and activated partial thromboplastin time. And in suspicion of thyroid storm, because of the other features or patient has exophthalmos or a thyroid swelling, then TSH, free T4 and free T3 also need to be ordered. But not that all investigations need to be done in all patients. Management of heat stroke, it's a medical emergency. We must activate the emergency medical services, call 108 and shift the patient and keep the patients in the hospital for at least 48 hours. And we have to remove from the on-site, we must remove the patient, put it in a shade, remove or change the clothes. Then initial ABC in all medical emergencies, we start with high flow oxygen, continuous pulse oximetry, apply the ECG leads and IV access line and start the fluid replacements. And room temperatures should be lowered, but don't make it the very low temperatures because patients might get shivering and that shivering will be counterproductive. So temperature should be lower, but we don't do anything that reduce shivering. That's very, very important. We can reduce the core body temperature by way of cold water enema, or we put ice packs at certain places like groins or the armpits or over the back, because applying ice packs will produce the loss of heat by way of conduction. That because of this, the ice and then touch to the ground that and the body, the heat will be lost by way of conductions. Then we have to correct the hydrations and the electrolytes. But the most important, the proven therapy is evaporative cooling. What we mean by evaporative cooling is, as I said, the conduction radiation will not be very useful because of the surrounding temperature is so high that it's not possible to lose heat enough by way of this mechanism. So what is important is that you sprinkle water over the patient's body and then start the fan so that the air is cooled, and that will reduce the lose the heat from the surface. And that's very, very important. And you can have a cold shower. So evaporating cooling is one of the most important method of saving the patients or bringing down the temperature at the earliest, right? So you apply the ice packs over the places, elevate the feet, and start a fan and keep sprinkling the water. And that is the best way. That will not produce shivering, that will not produce too much cooling. And once the temperature has come down to 39 degrees centigrade, we stop doing all these activities. What is important is bring down the temperature from 104, 105 to below 40, preferably below 39 degrees centigrade. It's very, very important. Paracetamol has no role, and in fact, it could be harmful because the patient has hepatic injury, and that paracetamol might produce more hepatotoxicity. Benzodiazepine we do use sometimes if the patient is agitated, because agitated patient might produce more muscle contractions and produce more heat. So for that context, only benzodiazepine might be useful. Chlorpromazine used to be the drug of choice earlier because it brings down the temperature, but not used routinely. It has its own adverse drug reactions, extrapyramidal reactions. Dantrolene sodium is one drug which has been unnecessarily used out of proportions, but it has actually no role. Dantrolene sodium is a postsynaptic muscle relaxant. Its role is mainly in the conditions where conditions like malignant hyperthermia, where there is temperature because of the severe muscle spasms and shivering, and that producing heat. So dantrolene sodium has no role as far as the heat stroke is concerned, and it's definitely not the drug of choice or should not be used in fact, right? If the patient has rhabdomyolysis, alkalinization of the urine in the form of continuous high intravenous fluids with sodium bicarbonates definitely will help. We may have to take the help of the nephrologist and the critical specialist in such situations, and that will definitely help. What is important over and above the treatment is how to prevent heat exhaustion and heat stroke, because that is what we would be spreading message to all our patients and their relatives, that they must take plenty of cold drinks, especially when exercising. They must take these showers and cool bath as far as possible. They must wear light colored clothes, loose clothing, that will help in the uh, evading the heat. Then sprinkle water over the skins. Avoid the sun in the extreme heat period, that is 10 a.m. to 4 p.m. They should use goggles, umbrella, hat, cap, right? They should be using full sleeve clothes and light color clothes. They should remain in the shades as much as possible. They must avoid, we should take more drinks, but that doesn't mean they should be taking drinks which are dehydrating, like alcohol, right? Or caffeinated drinks. They produce more dehydration by way of what? Diuresis. So avoid alcohol, avoid exercise. And most important thing is, we should not ignore early signs of heat stroke. If the patient has slightest mental symptoms, right, or the failure to perspire, that is a time when we must make sure that we get high alert and save the patients from place, right? Before I conclude, very important message, that remember that heat, particularly many times we hear such cases, unfortunate cases, that the children or the pets are left in the car which is parked directly under the suns, and you would not surprise that the temperature in the car, even if the outside temperature is 40 degree, it takes few minutes to turn into 49 degrees centigrade. degrees centigrade, and persons can be dropped dead in a matter of few minutes. So never ever leave the children in the parked vehicles, or even that applies to the pets also. Very important. And as I started earlier, that what is important is giving the shades. So we may, with our help of our NGO friends and all, we make sure that people who are constantly under the heat, right, whether two-wheeler people who are in the signals, like they may be, right, there may be some shades, and there may be traffic umbrellas, or as many water uh, available as we should be giving. And last but not the least, as we started with, it is the global warming, as somebody has rightly said, that we have to think for long, and we must grow trees so that that takes care of the carbon, because trees are the only one which removes the carbon. All other our activities are producing carbons, and we must try to reduce the carbon footprint in the form of all the vehicles exhaust that we lose. All. Thank you.
Thank you so much, Dr. Mahadev. So let's start taking up questions from the
Sure.
comments. Yes. Which is the ideal IV fluid to manage severe dehydration and vasovagal shock in pediatrics under the age group of 5 years?
I am not the right person to answer about the pediatric, but generally, as I said earlier, that most of the time, whatever it is, it's always start with isotonic salines, or 0.9% normal saline is the treatment. If we by elderly, as I said, sometimes we'll get the hypernatremic hypovolemia. Even there also, if you start isotonic saline, it is the perfect match. So isotonic saline remains the drug of choice. If there is, say, hypoglycemia because of the other reasons, you might give the plain water, and hypernatremia, then 5% dextrose in water could be the replacement. But isotonic saline remains the fluid of choice. Some people use the ringer lactate, but when there is a hypovolemia and there is a possibility of liver injury, even ringer lactate may not be the ideal fluid. So to me, the ideal fluid remains isotonic saline. I am not sure about the children what could be the ideal fluid. We don't deal with the pediatric patients.
Okay. Okay. Thank you, sir. The next question is by Dr. Kulkarni. What is the pathophysiology of convulsions in heat stroke?
There is a direct thermal injury to the central nervous system. There can be electrolyte disturbances. There can be ischemia. There is more than one reasons, right?
Okay. Next question is by Dr. Narendra Patel. What is your opinion about evaporation cooling techniques?
Yeah, evaporation cooling technique is, as I said, that because of the humidity, the normal evaporations would not take place when that humidity is more. So we have to keep on sprinkling the water and start the fan, and make sure that the water, because of the cooling of the water that we have sprinkled over the person's skin, that would take away the heat. So evaporating cooling remains the number one treatment. We can have many other ways of. People have tried the cold intravenous fluids also. People have tried the gastric lavage with cold water. People have given cold enema. But evaporating cooling remains the number one treatment.
Okay.
But we do not use the cold water, because that might produce the shivering, and that will be counterproductive. So that's why it's a normal room temperature water that is kept, and the fan is started from the one end.
Okay. Okay. The next question is by Dr. Akhilesh Tripathi. Which IV fluid is best for adults?
As I said, a normal saline remains the drug of choice, definitely. Later on, we start with the normal salines. See, in case of heat stroke, at least, it's not the fluid management which is the priority. Priority is cooling. Priority is bringing down the temperature. That is very, very important, because the temperature is very high. Fluid loss is not as much as we find in heat exhaustion. And exhaustional heat stroke, the things are different. But so giving fluids is fine. People have developed, because of the overfluid, their patient develop pulmonary edema. So fluid is not to be given in every excess, just like cholera or diarrhea, right? Here we have to start the fluids. We maintain the vitals. We see the patient's conditions and give it. But isotonic saline remains the fluid of choice. We don't use other fluids. Once we have got the reports, accordingly we can change the fluids. We may additionally give the calcium or the glucose as per the reports if required by the ECG or other changes. But normally what we start with only normal saline.
Okay. Next question is by Dr. Ajmera. How to manage paroxysmal nocturnal cramps occurring in completely healthy people?
I don't think that there is any related to the heat, but probably what we give, of course, there are no specific guidelines for this. People have tried different kinds of things, the magnesium supplements, calcium supplements. People have even tried the baclofens also occasionally. People have tried pregabalins, but there is no one correct answer to this question. Let me tell you honestly.
Okay. Next question by Dr. Rajendra Purohit. How much IV fluid in 24 hours and how to monitor hydration?
As I said that we just have already have our starting pulse rate as well as the blood pressure as well. We see whether the lines, the neck veins, and we may continue only the fluids. We don't, if the patient is in ICU and we have gotten cannulations that we may measure the blood pressure. Otherwise, there is not required. What we can see is the patient's vital conditions, urine output, hourly urine output that we can see and monitor. But most of the time, it's not an excessive fluid requirement. In fact, fluid has to be judiciously used, right? And there is no specific like diabetic ketosis. We have to give 1 liter in half an hour, another 1 liter in 1 hour, and total 4 liters in 4 hours. Nothing like that here. It depends on case to case basis. And in most of the cases, the most important treatment, I repeat, is cooling down the body temperature. That's number one priority. Second comes the fluid.
Okay.
Of course, if the patient has rhabdomyolysis, we have to give fluids. That is a totally different scenario. There we have to use fluids, forced diuresis. We give more fluids, we give diuretics, and if required, even dialysis.
Okay. Next question by Dr. Atul Parikh. Is it all right to use IV chlorpromazines in absence of other effective IV alternatives?
Yes, sir. As I said that we had been using earlier, but because of the side effects, now it is gone. But definitely we can use it. Otherwise, it's a safe drug and it does bring down the body temperature to an extent. So yes, we can use it and we have been using it. In fact, definitely, sir.
Okay. I think we are done with the questions. If we could like discuss something about heats of proteins, sir.
What?
If we can discuss something about heats of proteins.
Heat shock proteins.
Yes.
Heat shock proteins, yeah, of course, I did say that heat shock proteins have come a big way. That heat shock proteins are, when you read heat shock proteins in any of the book, then they would say that heat shock proteins are their important purpose. They are housekeeping proteins. So they have got and then action what is called chaperones. Chaperone is the word used when in the earlier time chaperone one the word was used when an elderly young royal lady is going out of the house, an elderly lady, wise lady will go with her. So that is the purpose of a chaperone. So these heat shock proteins, they are generated to prevent the proteins from malfunctionings. They prevent the apoptosis. They are different kinds of heat shock proteins. They are the amino acids, some 800 odds amino acids they produce. There are different varieties, HSP70, HSP90, HSP60. They all, their main function is they prevent the misfolding of the proteins, or protein has got a three-dimensional structures, and only if their three-dimensional structure is maintained, then their enzymatic functions will be working, their hormonal functions will be working. So heat shock proteins will prevent the unfolding of the proteins, or they prevent the apoptosis. So the further damage is in short prevented by heat shock proteins. So they are the housekeeping proteins. And nowadays, it's not that heat shock proteins are found only in the heat during heat only. They are first time found in the heat shock proteins, and that is why they are called heat shock proteins or HSP. In fact, now we find so many times these heat shock proteins in shocks and even in neurodegenerative conditions. They are used as therapeutic agents. In Alzheimer's disease, the heat shock proteins will take care of the misfolding that occurs because of the accumulation of these amino plaques and amyloid plaques. So heat shock proteins are coming a big way for the neurodegenerative diseases. Even as a cancer therapeutic agents, heat shock proteins are coming. But in heat stroke, heat shock proteins are there to prevent the further damage to the organs. So they are the housekeeping proteins, we can say.
Okay. was very insightful, sir. Is the use of salt tablets advisable? A question by Dr. J.N. Bhatt.
Uh, Salt tablets, see, without the water, wouldn't, unless the patient has severe hyponatremia. Again, there also we try to give the water and the salt. So I am not sure what is the very purpose of the giving the salts alone, because we need to give the water. Here, the fluid loss is from the interstitial compartments, not that there is a reserve fluid anywhere in the body. So giving salt alone might invite more problems. So giving only salts would not suffice.
Okay.
Salt tablets, I mean. There
Dr.
was one
J.K.
question. Yeah.
Yeah, which one?
How to manage heat cramps and rash with severe itching. Antihistaminics have been found to have some role in the itching. But what is important is the cooling with the cool clothes and the moisturizing creams. We don't apply very oily cream. We just apply something like electrocalamine or calamine.
Okay. Yeah, I think we have covered all the questions till now. So
We can have some comments also from the seniors. Well, like we have got Dr. Bhatt, we have got Dr. Tulpari, and we could see many seniors already attending. They can also have comments, their comments.
yes, sir, please.
They can give their comments and their experience. They are very experienced seniors. Heat stroke, the mortality in Delhi could be going anything from 25 to 50% if we don't treat in time. So that is why the best important thing is we must diagnose at the stage of heat exhaustion only and start the cooling. That is very, very important. Fluids come the second part, and rest is if there are complications we have to manage. Yeah, we can definitely give fruit juices and salt. Definitely there is all homemade foods or the fruit juices can definitely be given, and they are more palatable. They are more usually in the exhaustional heat stroke when there is too much of loss of salt in water. Definitely it helps. Dr. Tulbi, thank you very much for the comments. But if there any other comments or experience that we want to share with our audience, maybe Dr. Haley, we can wrap up with thanks.
Yeah. Yes. Okay. Thank you so much, sir. This was such an insightful session. Thank you so much, everyone, for attending the session, and hope to see you all soon on this.
Thank you all. Good night.
Thank you. Good night.